Hi, welcome to Two Guys in Scrubs. We are Two Guys in Scrubs. I'm Silas Radies.
And I'm Delbert Yip. We're second year medical students at the University of British Columbia, and we started this podcast to share what it's like going through medical school, discuss medicine, and pretty much anything else.
Please be advised that Two Guys in Scrubs is for educational and entertainment purposes only, and the views expressed do not reflect the views of our program or supervisors. So, welcome back. Welcome back, everybody. Thanks for tuning in. Today is a little bit of a different episode. I'm going to be solo today, and I'm going to be presenting an episode which includes a series of mini interviews that I conducted while recently away in Belgium, in Brussels, last week for the International Symposium on Intensive Care and Emergency Medicine. I went there to do a poster presentation, but overall it was an amazing experience. This is the largest symposium on intensive care in the world, and the sheer scale, the sheer scope of the symposium was unlike anything I've ever seen. The amount of talks and lectures that were going on 8 hours a day for 4 days with the world's leading experts. You get to hear lectures from the people that write the guidelines that we all refer to in clinical practice, and you get to learn kind of how the guidelines were thought, how they came to fruition, and kind of the difficulties sometimes in choosing certain guidelines, given the evidence and the current evidence that's challenging the current guidelines, and to be able to hear questions from the audience, other clinicians, intensive care intensivists, and finding out how people play within the guidelines, and how medicine is practiced differently from clinicians around the world. But I digress. Really, I'd like to present to you a series of interviews right from the floor of the exhibition of the Intensive Care Symposium, where I interviewed representatives from biotech companies and pharmaceutical companies that were hosting and representing their products and the new, latest, and greatest technology in intensive care right from the floor. So without further ado, I bring you a set of mini interviews from the 2026 International Symposium on Intensive Care and Emergency Medicine. Enjoy.
So, hello, I'm Olivier Bouvet. I'm a pharmacist by education. I'm spent most of my career to develop drugs in critical care setting, and I've been working on short-acting beta blockers, primarily S-model, for more than 24 years by now. And we launched Landiolol that has been originally developed in Japan, in Europe, because we are looking for a drug that would be better fits the critical care setting. So Landiolol is a new ultra-short beta blockers now available in mostly in Europe and now in the US, and of course Japan and China, Australia recently. And this beta blockers not only has a very short half-life of 4 minutes, it is destroyed by esterase, so it has a very short half-life, but it's also one very highly selective beta blockers with a ratio beta 1 to beta 2 of 255. So this is one of the highest beta blockers selective agents, especially the sole and unique injectable beta blockers with this high selectivity. It translates into a very limited impact on blood pressure and very limited negative inotropic properties, primarily because it does not interact, unlike S-model, with calcium channels and sodium, so the effect on the contraction is very limited, especially at low dose. And from the clinical standpoint, many clinical trials, of course, primarily in Japan, confirm this with an indication in the acute heart failure and patient with a rapid AFib. This drug is in the guideline, the European guidelines, and Japan to treat patients with a heart failure decompensation due to rapid tachyarrhythmia. In Japan, it is also indicated for ventricular tachycardia. It's not yet the case in Europe. We are working to get a label extension. This is really a drug that is very potent. The dosing is from 1 to 40 mics per kilo per minute. So you would start very low dose in a septic shock patient, for instance, or acute cardiac failure, generally up to 10 mics per kilo per minute. And in some patients like ventricular tachycardia, you may need to go higher dose, like 20 to 30 mics per kilo per minute. These drugs should be used 24 hours. You can be used several days in patients that are very critical ill, and it can be also used in combination with amiodarone. And when amiodarone fails, you can add landiolol. That's not an issue. We have data that are show the safety of this drug in this context. Thanks for your listening.
So my name's Alex. I'm an anesthesiologist and critical care physician, consultant working in Munich, Germany, and started working at Ebenbild, the company at which booth we are at the moment, part-time 2 years ago. And we are working on creating digital twins of patient-specific lungs. So, which is something no other device that we are using currently in the intensive care medicine, critical care setting, or anesthesia setting can do.
Well, that's absolutely fascinating, and maybe you could unpack this concept of digital twin. What does that mean for people? Of course, it sounds very cutting edge, sounds very interesting, but what is a digital twin?
So a digital twin is a functional digital replica of the patient's lungs in the computer. So we take a CT scan, and then we do image segmentation using computer vision and machine learning techniques. And then we have an anatomical model accounting for patient-specific geometry as well as pathologies. And then we functionalize that model by imbuing physics into this anatomical model. So then we really can compute how the air flows through the airway tree, as well as tissue distension, tissue strain, tissue stress.
That sounds absolutely incredible. And kind of what stage are you at currently with the development of the technology? So whether it be, has this been used on real patients? Are there real use cases, et cetera, et cetera?
So we have validated the predictive capability of this technology in several studies and published the results in peer-reviewed journals. But we have not cleared the device as of now. So we're currently working on preparing the clearance trial to get clearance for the software as a medical device in both the US as well as EU.
Well, I wish you the best of luck. That sounds very promising. And maybe as the last question, you could just elaborate a little bit on those trials, on those preclinical trials that you did, and kind of what kind of outcomes you feel like you're able to predict with this with a digital replica.
So for the studies that we did, we focused on validating the predictive ability of the digital twins. So what's super important is, like, if you create these twins and make predictions, not only assessing the state that the patient is currently in, but also allowing, potentially the physician to sort of change the ventilator settings in the computer to see the effect before they apply the settings to the patient. And so this is why we focused on looking at do the predictions actually match what you can measure in the clinic, right? So we compared the predictions against, for instance, electrical impedance tomography. This is the study that we just published in the Journal of Applied Physiology, and there's a poster also in this conference. And in addition, we also used 3D SPECT CT to sort of see if we can, also capture the regional air distribution in the patient's lungs.
Yeah, my name is David Thomas, and I work for Econis, and we manufacture portable point-of-care ultrasound devices. Our view is point-of-care ultrasound is an inevitable skill for all secondary care doctors to use. An important caveat is that's quantified point-of-care ultrasound, where you get numbers which allows you to make decisions, which means you advance the patient care pathway. The inevitability of every secondary care doctor using point-of-care ultrasound means that there's a massive training burden which won't be fulfilled by mentoring, which is the traditional model for learning point-of-care ultrasound. And that's why we integrate AI-based self-directed learning into our systems to allow people to take one of our devices and self-teach themselves the practical skills of learning point-of-care ultrasound. There's an interesting inversion which has happened, which is echo used to be considered the hardest skill of point-of-care ultrasound to learn. But in the realm of AI, because Echo is filled with features, it's got limited windows. AI has transformed Echo from being the most difficult skill to learn into one of the easiest, because you've got set windows, set views with set features, which are ideally created for AI to score the learning of. And there's an interesting fact, the evidence is starting to show that AI-based self-directed learning is now equivalent to mentoring. I think ultimately it will be considered the gold standard, because if you think of yourself mentoring somebody, there's no way you would hector them every second, move up, move down, step left, step right, in the way that instantaneous AI feedback teaches people to scan. So, I look at the future of medicine, secondary care, point-of-care ultrasound, where everybody has the skills to do quantified assessment. Everybody regularly uses the skills to do point-of-care ultrasound. And we have a model which, when deployed, ends up with much more prevention. I always think it's a great irony that in intensive care, you get your ultrasound machine out when the patient has got severely unwell. Whereas obviously if you can get them out of being severely unwell with point-of-care ultrasound, you can stop them getting severely unwell if you intervene with point-of-care ultrasound sooner. So, it's a great future for POCUS. It's a wonderful time to be involved. And really it's a cultural change to accept that actually this is going to happen, and the mode of learning will change. And because traditions are hard to change, it's just a case of persuading people more and more to think differently.
That's very interesting. And if I could ask two follow-up questions. The first being, so this is going to be an audio podcast, people won't see any video. I'm looking at the advertising sign at this booth here, and we see that you can use Cosmos to do a complete hemodynamic assessment of circulatory, of current circulatory, how would you say? Status.
Status,
Of
yeah.
course. Would you be able to give a brief overview of how that's done? Not too technical, but just in terms of how it might differentiate from other POCUS technology available, and how we can do a quick assessment of circulatory status.
Yeah, well, there's two parts to the answer to that question. The first is a principal understanding that effectively you have a triad. You have the lungs, the heart, and the organs of the abdomen, and they have a bidirectional relationship with each other. So you cannot assess any of them in isolation. You have to assess them all. The cardiac function may be affecting the organs, may be affecting the lungs. Lung function may be affecting the heart, may be affecting the organs. So you have to look at them all in a bidirectional sense, and when it comes to the heart, quantitatively. So where we see our unique differentiators is that we do continuous wave Doppler. And if you need to assess the impact of right heart failure, right heart dysfunction in terms of its impact on congestion in the abdomen, you can only do that if you've got continuous wave Doppler. You need to measure tricuspid regurgitation and quantify tricuspid regurgitation to be able to say, I know the impact that's having on the organs. Is kidney failure related to this? And a key thing in the economics of this is acute kidney injury. Because when you think of a program which requires investment in capital, you think, well, where's the money going to come from? But the costs modern healthcare spends on acute kidney injury are so high. The average episode of acute kidney injury is $11,000 to $42,000 of added care costs. So things like CW Doppler, when you look at actually assessment of prevention of AKI, become vital. So, you have to quantify every aspect, and that way you can make earlier decisions, which, when it comes to AKI, have profound impacts on delivery costs.
That's absolutely fascinating, and I have one follow-up question before I leave you. So, if I'm looking at the device that you're promoting, Cosmos, it looks incredibly portable. Like I see basically, for the listeners, I see a small tablet-type device, an ultrasound probe, and a couple of wires, something that I could easily fit into my backpack, for example. This is not a huge machine that I'm lugging around. So could you see a future where, let's say, a medical student like myself, if I wanted to take it into my own hands, could just purchase this device and use it on my own volition? Or do you think this has to be necessarily mass adopted by the hospitals for it to be able to be used?
Good question.
Because I would love to put this thing in my backpack. That's what I'm getting at.
Indeed. Well, there's a profound relationship between size and cost.
Yeah.
If you want to build a cart, certainly for medicine, there's real cost to that cart. So the smaller you can make something which has all the functions you need, then obviously the cheaper you will be able to buy that device. So, as a company, we foresee individual purchase of ultrasound devices as the endpoint. Right now, we're still in the enterprise. The hospital buys the devices and allows people to use them. And at some point, we're going to get to POCUS being not just a departmental skill, but being an enterprise-wide skill where the hospital has a POCUS director, they have POCUS programs which are enterprise-wide. And I think we're going to get into that before we get to people individually buying them. Can you individually buy it as a doctor? Yes, you can. And I think in people who are learning medicine today who have the resources should, because the self-directed learning that it gives you in terms of being able to practice your skills and acquire proficiency, I'll give you some numbers which are really interesting. If you look at the time it takes to acquire the skill of echo, there's a study in Denmark on GPs, you've got to do about 25 studies to achieve a basic competence. You have to do 50 or more studies to achieve proficiency. If you're dependent on a mentor and their time, those will take you a long time to get to. If you have access to the device and you have willing friends and family, you can get there in a few weeks. And once you've got beyond the basic skill, you're then into the secondary skill, which is machine optimization. Again, AI is improving because ultrasound is traditionally a very task-heavy thing, lots of knob twiddling, and people that are traditionalists tend to wear the skills like a badge. I took 5 years to learn this skill. And there's an implicit thing saying you've got to take a long time. Well, the revolution of AI is you don't, because the machine is doing those tasks for you. And so ultimately, we're aiming to try and get a device which anyone can learn, and it does all the tasks for them. So you get to the numbers. Nobody wants to do POCUS. What you want is the results that POCUS give. And so it then comes down to your skill as a doctor and be able to interpret the information you're given. So if you believe that POCUS is the future of secondary care medicine for all doctors, then I'd say yes. Any way you can get your hands on a device, you should do it now. And the sooner you do, the faster you'll get there. And it's just going to be a general medical skill. It's just going to be a standard. I personally believe that stroke volume will become as routine as a number as pulse, temperature, because it's such a crucial number in understanding the patient's physiological well-being.
So I'm here with Hunter from Integrion, and he's going to tell us all about VCM device. So maybe you could start under just for the naive. What is the device? What kind of problem is it trying to solve? What makes it stand out from other options, etc.
Yeah, sure. So the Integrion as a company, I'll start here. We're a North Carolina-based company. We, for most of our history, have been involved in biological products. A number of years ago, we had a biological product that was being used by the U.S. military under a contract that was meant to give an extended shelf life of plasma. In the field testing of this product, the military came back to us and they said that they needed a point-of-care solution to monitor full hemostasis. They needed a way of knowing when to provide this product. So the VCM was born out of that necessity for a point-of-care hemostasis monitor. Our instrument, measurement-wise, is a viscoelastic test, very similar to thermoelastography, TEG, or rotational thermoelastometry, which is ROTEM. Very similar measurement, but we've got a different way of doing it. We are the only point-of-care test, or only true point-of-care test available. It's a completely native, reagent-free instrument, so there's no chemistry at any point in the process. You use about 6 drops of native blood, so 300 microliters. Usually I have a fresh stick. It could be done out of a tube. Goes straight into your cartridge and then into the instrument. And then in real time, you'll have a monitor that assesses the birth, life, and death of your clot. So the change of viscosity over time. Right? We measure amplitude as the clot progresses.
That's absolutely fascinating. And then, so where are you guys at in terms of this product adoption? Either it be military, preclinical, clinical, etc.
Yeah, we have been commercially available in Europe since about 2019. Unfortunately, our very first placement was in Milan in November 2019. So COVID hit, and then we got kind of stuck out of the European market until about 2021, 2022. So we had a little bit of delay, even though we were clinically available or commercially available. In the U.S., we are going through the FDA process. Actually, we got a really big deal last year. It was called breakthrough designation through the FDA. So it means that the FDA has recognized when we are a unique product that meets an unmet need, specifically in neonatology, because we use such a small amount of blood that we have heel stick studies validating our use in heel sticks in neonates.
Well, congratulations. And we obviously here at the podcast wish you the best in the further adoption of this product. Maybe just from a more of an educational point of view, maybe we could discuss, of course, we have our, people are familiar with the standard lab tests that might be used to evaluate clotting time, hemostasis, and thrombogenesis, etc. I guess what makes this device, you just mentioned that the amount of blood is something that's unique, but maybe what else makes this device unique compared to traditional lab test results that we might be using? So from a clinician standpoint, what makes this interesting?
Yeah, it's going to be a kind of a mixed answer here. Part of it is the fact that we're a point of care instrument, right? So we're transitioning away from needing to rely on a lab to give you a result that may take several hours to get. Having an instrument at the point of care, having an instrument at the bedside allows you to have results in just a few minutes that you can rely on rather than waiting 3 or 4 hours for a lab to get back to you. So that's part one to that. Part two is that we don't use reagents that you see in a lot of laboratory instruments, right? There's a lot of data out there, not just on the DCM, but even Rotem presents data that shows that using a native sample without the influence of reagents helps provide a much more true to patient result. So it's an area that we're not the only ones targeting. A lot of people are heading that way, but we do it at the bedside, and that's where we're focused on.
Wonderful, and it's cool to see all the emerging point of care technologies that are coming out. I'm imagining just like as a clinician, as a student, soon I might be able to have just an array of things in my backpack, and be able to like provide comprehensive care. So it's very fascinating, and we thank you for your time.
Hi, good afternoon. So my name is Esmeralda. I'm representing Eferon. It's a European company manufacturing multimodal hemoabsorption devices. It's a new generation of hemoabsorption technology, we could say, because what we are doing is very unique. We could combine endotoxin and cytokine absorption in one device. Yeah, so currently the company is quite new. We got the certificate in 2024. In these 1.5 years, we are already represented in more than 40 countries. We are growing quite fast, and we see that there is a need for the product, and that's the reason of the quick global adoption of the product.
Wonderful. And maybe we could kind of start from the basics for people who are less familiar. Why do clinicians need to care about hemoabsorption? Why is it important in the treatment of sepsis and critical care illnesses in general?
Okay. To be short but informative, what I could say that current extracorporeal blood purification therapies had some kind of limitation in removing inflammatory mediators and endotoxin, because somehow if we're talking about cytokines, the size is big, and then the filters that we know, they have limitations of removing it. Also, there were no product focusing on endotoxin absorption. There was, but just in the toxin. So it's kind of, there is a very nice comparison between fire and smoke. In the toxin, comparing with fire and cytokines with smoke. And that means like you need to remove both. Just removing the cause of the problem in the toxin is not enough. Removing only the cytokines as a release of endotoxin, again, it's not enough. There was a need for a solution combining those two approaches. So that's the reason our company created the device, which can combine endotoxin and cytokine absorption in one. And also, we published a randomized controlled trial, and the results were quite interesting, showing that there is less ICU stay, less ventilation time. Overall, survival outcomes were quite improved. So, yeah.
So that's wonderful. And so you said that this product is being adopted. So it has been adopted, and it's currently being used in ICUs around the world.
Around the world, yeah, we have more than 40 countries already. And the geography is quite interesting. Australia to Austria, I don't know, Vietnam to Latin American countries. So we're trying to let physicians and more patients benefit from this newest innovation.
Okay. And that's wonderful. And if people want to learn more about the product or any other products, so what would be the best way for them to do that?
We have LinkedIn account, Eferon. They can visit. We have YouTube channel, Facebook. So we try to be like available in different platforms. And of course, we are in all international conferences related to the critical care.
That's wonderful. Thank you for your time, Esmeralda.
Thank you.
My name is Benjamin Raber, and I'm a representative of Nihon Kohden, and I'm responsible for the whole ventilation business across whole Europe. And now I'm demonstrating to you shortly some special features of our high-end ventilator, the NKV 550. So our ventilator is so-called app-based, and you will find tools that will help to protect your patient lung, and especially to support clinical decisions. And so our aim is to provide clinical relevant solutions with our devices. So, for example, we nowadays know that not all patients are benefiting from a recruitment maneuver in the ICU, and but might be stressed via the potential complications that are coming with the recruitment maneuver, like hemodynamic compromise, overdistension of the lung, and biochemical and microbiological trauma to the lungs. So therefore, one example is that we have this so-called recruitment assessment, where we're first checking if the patient lung is recruitable or not. Another tool is our inline suction app. We know that if you are sucking mucus out of a lung, you create resorption atelectasis and the lung will deflate a bit. With our solution, the device will maintain the open alveolars by increasing the pressure to compensate the volume you are sucking out of it. These tools are, in summary, combined in our so-called gentle lung tool, where you can easily get more information on our webpage or via direct contacting me. So these are just two features. Another thing that I would like to mention is that we also should look into protecting our staff, nurses, doctors in the ICU. Therefore, we have developed a so-called second screen, which can be placed up to 18 meters away from the ICU bed and is a full controlled user interface where you can change settings, decline alarms, make adjustments, or having lectures for clinicians that everyone needs to be standing around the bed. Or if you have isolated patients, you don't need to step in just for doing a measurement or just for adjusting a ventilator setting. You can do that outside of the room. That means also you save time
You don't need to put on gloves, PPEs, cover yourself, so you save waste, costs. Yeah, you're not disturbing the patient, and especially if it's a immune-compromised patient, you're protecting him. If it's an infectious patient, you're protecting your stuff. So these are some of the features that we are having in our solutions. And if you'd like to know more also regarding our other solutions that we are providing, feel free to contact your Neon Codon representatives. Thank you.
Okay, so I'm Elizabeth. I'm emergency room nurse, and I started working for this company now about a month ago. So the company is Neuroptics, which is the mother company of the product NPI 300, which is pupillometry. And so what is pupillometry? It's actually, like looking at the size of the pupils as a vital sign for any neurological problems. Usually in most ICUs around the world, it's still done with just a little light flash into the eye and see if the pupil is reactive or not. But now we have the technology that makes it possible to really put a value on this so that we can reduce the human error and that we can track the trends of the pupil of a person in time and see the difference and to see at what point actually something is starting to happen in the brain that we would not be able to see just with a little light in the eye.
That's super interesting. Would you be able to give us a few examples of how this technology is being applied, like in the ICU? So it's great that we can. Of course, it has a much higher sensitivity of detecting some of these pupillary abnormalities, but then it's kind of like, so what? Then what? How can this information help us to help patients?
So here I know in Belgium it's used in a few of the university hospitals in Brussels. And I know that they really use it as a standard vital sign for neuro ICU patients. So every patient that comes with whatever that is brain related is going to be tested every 2 hours. So every 2 hours, they're going to have one of the readings of the NPI. And so they can really see if there is any difference, because then it really makes sure that you have a basic value that you can compare to when the patient is getting neurologically worse. Because in the beginning, maybe it's just going to be normal, and then you continue registering it, and it's then you start seeing a slight difference, but really nothing actually major. But then the 2 hours later, you see it's again a little bit less, and so you know there is something happening, and so you can do early imaging to see if there is anything wrong, if there is a stroke happening, if there is a bleeding, and so you can take the problem before actually the symptoms show, and so it's earlier on, and so it gets better more rapidly. But you could also use it in the emergency room, because our product doesn't interfere when, like, there is no difference if there is certain drugs that will be used or opiates or stuff like that. So when you have someone coming into the ER that is like really agitated and you don't know if something, it's maybe just like a brain injury or a stroke or something like that, or if it's actually something drug related, this can also give you information, because if the NPI value is normal, then there is a big chance that it's more drug related and that it's not a brain injury. Doesn't mean there is no brain injury, but it's already going to put you in one direction or the other. So, yeah.
Wonderful, and thanks for your time. I just have one more question. So, clearly the device is measuring the size of the pupils. It's measuring the reactivity. But in terms of the reactivity, is it looking at is it looking at speed, like velocity in which the pupil changes size, for example?
So yes, it's actually a lot of different values. So it's the diameter, the maximum and minimum. It's the percentage of change in that diameter. It's also the velocity of contraction, the latency of contraction, and also the dilatation of the pupil. So it's all of that that is taken together, put into an algorithm, and that algorithm is going to give you that NPI score.
That was Two Guys in Scrubs. If you want to support the podcast, leave us a like or review wherever you listen to your podcasts. Thanks for listening, and we'll see you next time.